Next, I'd like to introduce Mr. Nelson Jim. He is the Director of Cultural Competence and Client Relations for the San Francisco Department of Public Health. He has also been the Clinical Director of Outpatient Mental Health and Substance Abuse Services at the Native American Health Center in San Francisco. Mr. Jim has over 15 years of experience as a mental health, substance abuse, and HIV clinician. He also has extensive experience in developing, implementing, and integrating policies and practices to promote and develop effective cultural competent healing approaches that are sensitive to underserved and ethnic and cultural communities. He also serves on several national advisory and public health policy board committees. Please join me in welcoming Mr. Nelson Jim.
Good afternoon, everybody. Let's try again. Good afternoon, everybody, my relations. Thank you. Yat shideya Nelson Jim yinshia. Nanash ajudina trabahansla kia ani bashchin. Bin pitwa ni twadich ini national dot is the sun the shiche. Sadliga des art sabane kahozana ag ado isi de nanshla. Yat yo bashit wajon ban kitwansloni. Good afternoon, relatives and all my relations. My name is Nelson Jim. I am Whitecorn people Zuni Edgewater clan, and I'm born for the Towering House people. My grandparents on my mother's side are the Minigoats people, and on my father's side are Deerwater Bitter people. I'm originally from White Mesa, Arizona, which is on the northwestern part of the Navajo or the Nez Nation. And I've been basically here in the Bay Area for about 20 years. And I just wanted to introduce myself also in my language, and just to acknowledge all my relatives and also all my relations, not just the people, but of all the elements. So I'm very happy to be here. It's a really tough act to follow. Some wonderful presentations this morning and also right after lunch. So, you know, if I ask you to stand, that's probably because I've seen people kind of nodding off or something. But I'll try not to go there. I want to talk about some things. I think I didn't really bring a lot of data specific because I really wanted to kind of honor also some of our own traditional indigenous ways, which a lot of what we carried on for many generations and among our people are through oral tradition and also just by practice. And I think a lot of what I want to convey, hopefully to you, will address some of the issues I think Dr. Braveheart had talked about, and also Dr. Walters, and also what Michelle has talked about, as well as Dr. Ethan Nibelkoff. And a lot of it is really my work, the work that I've done with my community here in the Bay Area. I am urban native. I've been, like I said, here for about 20 years. I'm originally from, I come from a reservation born and raised. I didn't leave the reservation until I left for college. So a lot of what, how I understand the wellness and also the indigenous healing comes from a lot of the, what I was exposed to, what I practice, what I've been taught, what I participated in, which I try to, in different ways, try to bring to the people here in the Bay Area, and a lot of the work that I've done since I've been here. Currently, I'm the Director for Cultural Competence and Client Relations for the Department of Public Health, and I've been there for a short time. And it's definitely a certain different system that I'm working with. It's an exciting place for me to be, but I'm also really missing my work with the community, the direct service I was providing for the people here in the Bay Area, not just San Francisco, but the whole San Francisco Bay Area. So I want to also honor the indigenous people of this land here, the Ohlone people, and all other California natives, because we have a strong, vibrant history that and a resiliency and you know the strength that helped maintain a lot of our indigenous people here in California, but also from all over the indigenous world. So I want to acknowledge that, and also want to acknowledge all my colleagues that have gone before me. A lot of things I think that we are talking about today has been something that needed to be said, has been something that I think we're in a place now today that we need to say that. We need to be the ones, and I think it's very touching, and it's a good inspiration for me to hear and see from my people a lot of our own history, a lot of the impact on what has happened to our loved ones and our ancestors, and how that impacts us today, because historical trauma isn't something that happened yesterday, it just didn't happen something way back when. It's happening today. It's something that we live. It's something that impacts our wellness in all capacity. That is something that we try to unlearn. But most importantly, one thing that I've learned as a clinician is some things are not resolved or begin to be resolved until it's acknowledged. And something needs to be named. And I think in a lot of that, we face a lot of challenge in that to try to name, to try to really in some ways begin to articulate and begin to understand, begin to in some ways begin to dialogue what is really happening to us as Native people. Not those people over there, but as us. What is happening within our own family system? What is happening within our own programs and our community programs? And the responsibility that we have, therefore, as providers, as researchers, as academics, etc. So, and I know we have a lot of elder folks here with us, and I just want to say thank you for their strength and also their perseverance and their determination to maintain through all that we have gone through some of the things that we hold on to today and some of the things that we try to in some ways use within our healing systems, within our social service systems. So I was just informed that there are people from all over that came here, and the importance of needing to have this information for an importance for us to be together. There are people all the way from Wisconsin. There's a whole group came from Arizona, like 14 of them. There are people from Washington. There are people from all over. So this is a wonderful occasion. And on behalf of the county and County of San Francisco, I just want to welcome all my relatives here. And also from the Department of Public Health, because I think my work today really is much more about policy. Is much more about a different kind of representation for my people, but also for all ethnic people and all cultural people and people that are underserved in our communities, whether it be San Francisco or anywhere else. Because I think sometimes we can look at the data, we can look at a lot of the things, but numbers don't really mean anything until you walk across somebody, your own relative on the street, who is basically has been homeless and living with HIV, and basically has a scar on their face and has, there are things, that's when it becomes real. And I think these are the things that I think we need to talk about. And so today is a good day to live. A little bit of information about the urban community for our Native people. There's about over 4.1 million people in the States. This is a little dated. And many different groups and subgroups. So also, the majority of the Native people today live in an urban setting or have a long migration back and forth between urban setting, maybe rancheria, reservation, pueblos, different villages. So for urban people, there are many of us here from many different locations from across the country. In the Bay Area, there's about 80,000 of us that either identify as Native people or also that also identify as other. Bay Area is also one of the largest concentrations of Native people. And sort of a little bit of history, I think we saw some of that in an earlier presentation, is we come from many different places. A lot of the migration happened during the relocation years, 1950s and 60s. So a lot of the people that we work with here in San Francisco are really second, third generation, and really to see some of the intergenerational transmission of trauma, but also looking at how our culture and how the work that we do and how we maintain community has also evolved and has changed. Today we have a very strong recovery community, and it's also recovery not just from substance abuse and alcoholism, but also recovery from historical trauma. Also recovery from a lot of things that we have endured and continue to deal with today as Native people. Urban Natives were very multi-tribal, multicultural. I think a lot of my relatives that I know also maybe like part Latino. My nieces and nephew here. My niece is here in the Bay Area. I have a sister who lives here. My three nieces that are here One, a quarter Navajo, a quarter African American, a quarter East Indian and Sri Lankan. The other one, African American, obviously Native American, Salvadorian, and also Filipino. So this kind of demonstrates just the multiculturalism of who we are. And that in some ways it puts us into finding an identity as a group. And Pan-Native American identity is sort of something that evolves sometimes, but we're also very invisible. I think for a lot of people that live in urban setting, sometimes people don't believe that we still exist. We get mistaken for many different things. So, but it also sets us up for a lot of different health disparity, which I'm going to kind of talk about a little bit. It also has a lot to do with funding. Everything is data-based, everything is evidence-based, everything has to do with numbers. So in a lot of ways, that has a lot of impact on the kind of funding, the kind of services that we can access. We're very isolated. For a lot of our community members, we don't have as somebody mentioned earlier, we don't have a community or a neighborhood. We don't have the hood. We're very dispersed. And for many of the people that we provide services to that really need the services are either in SRO, single room occupancy hotels, they're in shelters, they're living with somebody. So homeless is a huge factor with our people here in the urban setting. Also, for a lot of the families that I know that I've worked with in San Francisco, a lot of them are in the system. So this means that either because of child abuse history, it might be because of a whole range of different things, they're in the system. So how does that impact also the identity formation of our people? How does that also really, when you come providing treatment, how does that impact the prognosis? For many of the work that we've done and the work that we do and with our urban community members, our prognosis is very poor. And that's just before we even start providing any kind of treatment. As I talked about in the community, so health disparity issue and also wellness issues. As we kind of saw earlier this morning, I just want to not to spend too much time, but it's obviously there's a whole array of issues that our people deal with in an urban setting. Some of the things, I just want to talk a little bit about spirit loss and also soul loss a little bit later on, more specifically in how do we work with traditional approaches, cultural approaches, and maybe beginning to at least address some of the issues that comes with it. High rates of diabetes and heart disease. And also in this, in terms of when we talk about historical trauma, it's very important also to kind of maintain what the impact of sovereignty on our people, and also what does that mean in relation to treaty agreements? What does that mean, and how does that also basically affect our health care? What are the reality? What kind of funding, what kind of support do we get from the federal government? Lack of funding, IHS, same thing. The responsibility of Indian Health Services to provide services to all Native people, but they don't. And for urban Native people, as I think Ethan demonstrated on his slide, they only get about 6% of funding. Which really, what does that really mean? Does that really mean that they basically fund a half a person for each department? Now, is that really sufficient for when most of the Native people are living in urban setting? And also, what are the support and what are the infrastructure, what are the capacity that's in place in order to provide, at least begin to provide a place in a room with a phone, with any kind of tangible system to begin providing some level of services and ongoing services. A lot of things that we deal with as Native people is also with a lot of stereotype. A lot of people, oh, you guys have casinos. There's only a small segment of Native people. And one of the issues that I dealt with, I was doing a presentation on historical trauma not too long ago, and somebody in the audience raised their hand while I was talking about this, and they said, well, don't you get a lot of money from the casino? Well, I in some ways I was glad that it was asked, because then I can make some clarification. And our clarification was, we only had, my work with the Native American Health Center here in the Bay Area, and the 10 years I've worked with them, We only had one donation of like about 400. And that is nothing compared to the 25 million that we were able to get on our own. So these are, I think some of the things that mystify who we are. As urban natives, we're many different things. We come in many different shapes and forms and sizes. And also, I think for the people that we provide services to, they come with so many different health disparity issues. As Michelle demonstrated with when you really put it all together, where do you begin? How do you begin to even let's not even talk about diagnosis. Let's not even talk about assessment. But how do we even, before we even have a client come in or have one of our relations come in, how do we connect with them? And where do we go once they come in? So I want to talk a little bit, therefore, about some of the things that I found to be very effective in my work. And also, one thing I just want to add as I was talking about some of the issues. The Bay Area community, at least not just the Bay Area, but all urban communities, one, being Native, there's a lot of issues around identity, the identity formation of Native people. One, tribal, maybe nation specifically. Are you Navajo? Are you Lakota? Where do we come from? Also, a lot of the issues that's attached to that, as it was so eloquently demonstrated this morning, is the shame that comes with that, and the shame for a lot of our people to even in California, not too long ago, you don't want to be identifying as a Native person because your scalp was $5. So these are things that I think we've internalized and we maintain. These are the shame that sometimes when you're Native. In my work with the Friendship House program in the health center, I've worked with a lot of people in recovery, and often I always have people, my clients, community relations, come in and ask me, "So, are you really Native?" And I ask why, and they say, "Well, I've never met another Native who doesn't drink, who's educated, who's kind of got their act together." What does that really mean? What that really means is we have internalized everything that has been projected onto us. Everything, and we've come to believe that we've come to also believe further even more. Can we get better? In my work and doing private practice, one of the questions I ask at some point is, what do you really believe? Considering the symptoms and all the issues and whatever it is that you come in with, what is your belief? Do you think at some point you're going to find peace? Will there ever be peace in your life? Because for Native people, that's a huge factor. With everything that our people come in with, hope is the furthest thing from them. It's on a daily basis. Dr. Walter just talked about that a lot of our community members think about historical trauma on a daily basis. That doesn't mean they walk around like, oh, the constellation of how does this manifest in my life? No. It means basically that our people are walking around thinking, am I going to be safe here? Am I going to get attacked if I get from here to here? Am I going to be able to have something to eat today? Am I going to be able to have access to a program that's going to be sensitive to my needs, that will be able to, where I'm going to feel some level of comfort? Will I be questioned? Will somebody look at me in a funny way? So these are, I think, on a daily basis, what our community members deal with, and how do we begin to address that, and how do we even begin to get them to a place in a clinical setting or in a ceremonial setting where they can say, okay, let's really talk about it. And to get there, for many of us, we can barely get there. So, and the issues, whether aside from tribal affiliation, aside from cultural affiliation, the transgender community, the LGBT two-spirit community. These are, by far the most at risk within our community. They're the most disenfranchised, the most on the outskirts. And when we provide services to them, how do we get them in? Do we just put a nice poster on the wall? Do we, just have, smile and say, oh, I'm so glad you're here? It's beyond that. And I think in a lot of ways, when we do outreach, when we do bringing our people together and beginning to bring a place together, it's not really about health. It's not really, to them, it's not, oh yeah, give me a pill and I'll be done with it. Give me a shot, I'll be done with it. The bigger part is how do we begin to bring in a culturally relevant, a culturally sensitive, healing approach, relationship, a safety that they feel safe with, that they feel comfortable with. That is in itself healing. Because it's not about the instrument that we need to develop that will be very good at giving us an assessment that therefore we can diagnose. So part of a lot of the work that I've been really focusing on with my community here has really been how do we bring in cultural healing system, and also methodology, and also cosmology, because it's a much more of a broader worldview. A big part of it is really very basic and very simple. and where I come from, one of the things that I remember so vividly on a daily basis, which I still do, maybe not every morning, but we always get up before the sunrise. We always get up before the sunrise because the morning god's coming to the east. So we take our corn pollen or white cornmeal and we say our prayers. And this is how we start the day. Today we're going to do this and this and this and this. This is how it is that I want to be in this world, and this is how I start my day today. Today we have something called Indian time, which is a negative stereotype that we have internalized and say, oh, we'll start at Indian time, meaning that we're going to be late. Traditional people, we were never late. Our ceremonies were organized, and our ceremonies and the things that we had to do, the healing practices and the healing ways, was well organized days before. So we took care, so we honored not just the four directions. We honored all relations in these directions. We honored also all the people and the spiritual people. And whatever it is that is given to us within our cosmology and our creation stories. So this kind of goes back into sort of what I was talking about, is the concept of balance versus health, the concept of wellness versus health. Health in the Western contemporary sort of healthcare is really you get your physical done. You may take some medication, and then you come back and try to come back for a follow-up. Well, that's really deficiency-based, because when do we see, if that's based on that model, when we do see somebody that's going to help us is when we're deficient, we have a cavity, we have something broken, we're depressed, something's not right. That's when we see. No wonder there's so much shame about that. No one wants to come. Traditional cultural wellness methodology has a whole different setup. It means that, my grandson just came back from far away from beyond the four sacred mountains. We don't know what he was exposed to. We don't know what he has seen. We don't know how, in some ways, his spirit and his own essence was maybe imbalanced. So we need to bring him back. We have to do his thing so that he comes back and that he becomes and then balances again. So this is basically the concept that we're always balancing. That in fact, we at some point should plan on seeing that medicine man again, seeing that grandfather again, seeing that uncle again. But it's also a time when our community members, our family, come together. It is a specific, strategic, intentional intervention methodology practice that really made everybody responsible for all of our health. And how it is that we practice also the medicine ways, the medicine bundle. That when I introduce to you that this is who I am, that's who I am in my relation. My name, in a lot of our culture, we don't use our name. My father has lost a lot of siblings in the last few years. And throughout my life, I never heard him use the given name, the English name, for my aunts. I had 4 aunties, 3 of them passed in the last 3 years. And it was always Nabija, meaning that that's your aunt on your father's side. And until they had passed on. Today, she doesn't talk about Nabija, she talks about Evangelina, you talk about Eveline. What does that mean? Well, it was a very sacred thing. In fact, it's basically to talk about, to basically have a relationship where it is very direct. It is beyond just, you yourself. It really was about keeping the system together. So when we talk about, from the traditional side, how do we bring this into maybe like Native American Health Center? How do we begin to even understand the importance of space and place? Like I said, we don't really wait until the last minute and put our chairs together and try to put up some stuff. These are things when my mother was, when we had a ceremony, she'd be setting up the days before and cleaning up. And she'd put mats all over the hogan. And I just say to her, no one comes. Nobody's going to come. And then she would say, the spirit people are going to come. The loved ones are going to come. The people that are going to do the ceremony are going to come. That's who it's really for. So how does this translate into our office spaces? And this is kind of something that I try to teach and really emphasize to the people that I work with, is make sure that your office space, it's not your space, it's the people's space. If they're coming in, got a lot of things going on in their mind, or they're psychically numb, they're a little bit dissociated, they maybe have been using, something's just not right. And I got stuff all over the wall and just hanging everywhere else. How does that conducive to healing? And as a practitioner, as medicine people, sometimes we get into our place, not because we want to be medicine people, not because we want to be healers. Sometimes this is just kind of our way that was given to us. But that's our responsibility, is how do we maintain the space? It's not just the office space. If you go back to what Katrina and also Maria was talking about, we have a certain affinity and a certain connection and a certain relationship with our place, our homeland. We have names, and our traditional names, for all the places that are very characteristic of where they're at and our relations to us. So there is a strong, and so how do you bring that back into a healing setting? Because if that's kind of where we do our sun dances, that's where we do our Inumi Way ceremony, if that's where we do our Beauty Way ceremony, how do we try to also take some of those principles and way of doing things into our healthcare system, so that we are not just connected just within our Samarillo staff, but also with medical care, primary care, also with HIV services, maybe with dental services, because they're all interconnected. We live in a world where everything, my work right now with DPH, everything is in silos. And I can see how it is that it's really difficult to work. So the importance of space and place is huge among the people, and in doing some work within your own community, that's one of the first and most important things to really establish. And if you want to create a nice, warm, secure place, you have to maintain that. There are also policies and procedures development. How do we make sure that we maintain confidentiality? How do we make sure that our clients, maybe who is two-spirit and actually very flamboyant and dresses very flamboyant, how can we make sure that they're who they are? How do we also make sure that our people that are using are able to come in? Because we all need healing no matter where we're at, what level of recovery we're at. The importance of relationship and community. Everything that we do and everything that is done in traditional ceremonial ways and also in traditional community is about maintaining and not about the Western concept of individuating. That at some point we're going to be on our own. But really, that the normal developmental process for our Native people and Native community and indigenous setting is we have connection, that we have a community. So a lot of my work today, really, I try to bring this and I think to what I'm doing today with city counties around cultural and linguistic competency, which also means a lot of different things, but specific to my work here means that as far as the language, it's not that, I can speak Navajo and I can work with all the Navajos in the crowd. It's more about also the language of how do you communicate? What is your body language? And some of the and for doing the work in clinical setting, you have to also work on your own issues. Because when there has been a lot of trauma, it directly and explicitly impacts the attempt to even develop an intimate relationship with somebody. Because in order to develop something and to help somebody feel at some level of their self-continuity, I feel okay, this person likes me, I feel something really good here, and not get caught up in your own work as a practitioner, this person kind of getting, sexualized projection coming out. How do I hold that? How do you work with that? Because that's when there's a lot of trauma, it distorts our sexuality, it distorts our sensuality, it distorts our body and the sensory awareness. A lot of my work, I'm trained as a somatic psychotherapist with body-centered psychotherapy, so a big part of my work is around how, as somebody, I think Katrina was talking about, how do we enculturate and how have the historical trauma, how have we internalized that? And how has that become part of every molecule and cellular level of our body? So there are research about people that's been exposed to extreme trauma. How does that also affect their brain chemistry? How does that affect the way they are on a daily basis? Are they hypervigilant? So if you're tight all the time, how does that impact your health? How does that impact your breath? How does that impact your own body's ability to maintain balance in a very complex world? So these are things I think I just want to just put out there, because they're not just the poster on the wall and the fact that I speak Navajo. It's beyond that. Cultural wellness and education is a very important piece. I think a lot of it, we're getting some of that here today, and I think we can never learn enough. And with the urban community, there's so many different places our people come from. So I think a big part of it is how do we, with some sensitivity, learn also about and how we want to work with them. And also our limitations. Coordinated and integrated services, I kind of talked about that because a big part of it is integrating the services so that there's less gaps, but also there's communication between the practitioners, but also that we bring and integrate a more traditional approach, a cultural approach, which is about community setting, which is about maintaining the space for the people. Healthcare center as a cultural center. We, for many of our relatives in urban setting, we don't have that cultural place where we all play bingo. We don't have a place where, we go Friday night just to hang out, because we don't. But how is that for somebody coming from a very community-based, community-oriented background, experience? So it kind of goes back to isolation. How does that impact our emotional health and spiritual health? So a big part of around some of the issues involved with it to really kind of keep in mind are around confidentiality. Because that's kind of, when I went to Alaska and Anchorage, where was the first place I wanted to go? The health center. Because that's where the native people are. That's where people are selling arts and crafts. That's where people are doing things. But it's also a place where, so therefore, how do you utilize that so that maybe if you're in mental health like we were, or like I was when I was working at the health center, use that mental health service as a culturally appropriate spiritual wellness program, developing a gathering, a women's health day, a two-spirit wellness group, things that, maybe they're not showing up over here at medical, maybe they're not showing over here in dental. But if they show up over here, these folks can come over here and say, you know what, you need to come back for another appointment. But also let them know that we're having a luncheon. I invite the practitioners, I invite the doctor, so that they are among the people like our medicine people are among the people. So that's the way I think in my work as a native and understanding where I come from, how do I integrate that and how do I facilitate that in an overall setting, an overall perspective? And the cultural consultants and practitioners have been a huge factor or a huge resource. We've been lucky enough to be able to integrate a lot of that during my work at the health center. And I think Michelle kind of talked a little bit about that, just the importance of how do you work with them. Providing a lot of education, providing a lot of, letting them know what they're going to hear about. You know, give them a rundown so they're not sitting there kind of shocked and then that's kind of re-traumatizing the client. But really understanding like, okay, and also maybe is this part of the therapeutic clinic, you know, individual therapy that you're doing with them? Have they made an accomplishment? Have they finished a recovery program? Have they graduated from a program? Or have they lost somebody? Or have they reconnected with somebody? So we bring these people in order to help them honor that. So in that way, one, we give them the opportunity, two, we teach them next time, you can do this on your own. So a big part of, and also working with, you know, providing education maybe to some of our colleagues, that we can't just bring a traditional person in and say, okay, you know, we just want to have you do whatever it is you're going to do with us. And the traditional person's kind of there like, okay, I think I'm going to just sing a song, I'm not sure what I'm supposed to do. There needs to be a very specific sort of agenda. What is it that you want? And maybe is it a health disparity issue? Is it an issue that is happening with a lot of our community members that might be related to spiritual wellness, you know, issue? So that they kind of have something to kind of go with and give some perspective on. So a big part of it is how do we bring these people in and how do we have them? I always tell the people sometimes, because I know that from my experience, a lot of people show up. When we did the talking circles with Richard Deertrack and with Lonnie M. Hula and with Mona Stonefish, people show up. And not only do they show up, they come together, they dressed up, they come in families. This is the impact of our traditional people on our, and this is so needed. Maybe not so much in urban setting because there are Native people and there's traditional people everywhere, but here we don't take it for granted. So knowing that, how do we intentionally, how do we strategically utilize them and help in our community members? But also how do we take care of them? So traditional people and traditional healers have a certain place in our community. And again, something that my mom always did, I always seen, is they always get the best part of the meal, the best seat in the house, the best blanket to sit on, so you honor them. I don't have a lot of time. But sovereignty issues I just kind of want to talk a little bit about, because this is a huge thing. An issue that happened in the early, I think 2004, 2003, an incident that happened at Havasupai. That they basically, to make the story short, there was a lot of blood samples that was taken from most of the tribal members of over 600. What the idea that the researchers from ASU was basically going to help them address diabetes in the community. Basically 22 publications were published. Only 5 of them had to do with diabetes. The rest, which is the only research that the community and the people consent to. The rest of the 16 publications had to do with inbreeding within the people, had to do with schizophrenia within the people, the community, and also the Bering Strait theory, that mainly is this a place that they really come from and it's not really their place. So what does that really mean? This is historical trauma. Much of the blood samples were never returned. Some of them were lost. Not only that, some of the studies were also studied against another traditional people, indigenous people in Africa. So these are things I think we have to be very conscientious of. And these are things that are very central. So again, the policy continues, the practice continues. Does somebody, the way I see it and the way I understand and the way I interpret it, maybe I'm running with it, but so be it, is somebody's telling me that I'm crazy? I'm so crazy I'm inbreeding? And 2, I'm not even from here. I think these are things that should not be taken lightly, and these are things that IHS has not yet to take in responsibility on, because it was the IHS that opened their center at night so that the person that was doing research was looking through all the files without any kind of consent. So these are things I think we have to kind of keep in mind when we're dealing with research and also with studies. Two, some of the jurisdictions and some of the legal things that protect us as Native people doesn't exist as soon as we step off the reservation. What does that mean for the 60% of our Native people that live in an urban setting? They have no protection. They cannot be represented by their own tribal government because they're not living there. So when you are encouraging people to go to some research thing here, HIV, diabetes, this and that, be very aware. What does that mean about who we are and the value of our bodies? And also, when we talk about bringing in traditional ways and traditional methodologies and principles, and that we, among our people, we never owned that. Not one person owned that. So that's something kind of also to keep in mind, that if you are integrating certain practices, but keep in mind this is the people's practice. It's the elder. It's the medicine bundle. And also, as if you're working with your own people as a Native person, it is also your responsibility to be aware of this, to maintain this. This is what sovereignty is. It's not the fact that IHS is supposed to pay for all of our medical bill. It's not, it's beyond that. It's something that, how it is that we take care of ourselves. Around data, I mean, a lot of data is very much deficiency based, a lot of medically based, a lot of what is wrong with the people. I think the more recent studies has really included a lot more cultural resiliency factors, protective factors, a lot of things that are very effective that we can have ownership of. So there's definitely some change going on. Just overall, I think there is a strong push to really include issues of race, culture, and ethnicity and healthcare. So that's going on. And so at the end, I think really what I do want to say is, when a lot of the work that we do in terms of culturally relevant and maybe traditional methodology we bring into our services is really about helping our relations heal the relationship. It's always going. It's always allowing people that they have a place in our circle.